So welcome everybody to this version of Lipid Insights. We really appreciate you joining us today for what I consider, because I'm a geek, a very exciting topic, which is that we now have an expert opinion statement from the National Lipid Association on familial chylomicronemia syndrome. This is a rare autosomal recessive disorder, but for the patients who have it, it's really a difficult problem. The patients have severe hypertriglyceridemia and recurrent pancreatitis. The usual culprit is a mutation in the gene for lipoprotein lipase, but there are four other genes that, when mutated and when the patient is either homozygous compound or double heterozygote, they can present with the disorder. So I was excited to see that we have an expert opinion paper coming out from the NLA, which will help, I hope, all of you in the audience and all of our colleagues recognize the disorder and diagnose it, especially since there is a therapeutic agent that was just recently released for the treatment of this disease. And I'm just going to make a comment I've made many times in the past, which is these are the only lipid patients that keep the lipidologist up at night, because despite our best efforts with triglyceride-lowering therapies, the patients really have minimal to no response to those therapies, and we worry about them. They still keep coming in regularly with acute pancreatitis, and in the past, we felt helpless. The patients certainly feel helpless. So we're going to dig into that a little bit with the first author of this position paper, Dr. Fiza Javed, who's a family resident at McMaster University. It's important to have Canadians on our podcast as much as possible. And we're happy to have you. We're not trying to annex Canada. That's a joke, I hope. Secondly, we have Nivedita Patni, who's an associate professor of pediatrics at UT Southwestern in Dallas, and is very well engaged with this particular disorder. So let me start with you, Fiza. First of all, congratulations. This is really a wonderful accomplishment, especially as a resident, for you to help us with this great position paper. How did this come about, and what made you interested in writing this paper? And did the NLA reach out to you to do this position paper, or why did this come up at this time?
First of all, thank you so much for having us. I think this is a really important topic, probably a little biased because I'm very passionate about FCS. The way it came about was actually I wrote a paper earlier a couple of years ago on patient perspectives on FCS from patients that I know. And I personally know about 10 FCS patients that I've spoken to, some of whom had very difficult time, some women, especially during pregnancy. And I had personally known Dr. Hegley, and we had talked about therapeutic plasma exchange papers that I had read. And we were just discussing there needs to be some sort of guideline or suggestions, because some of these patients are not offered some alternative treatments. So we thought maybe having some sort of recommendations on paper might help people refer to and clinicians to know a little bit more about the condition and what options there might be out there for this rare condition.
Yeah, and I think you did a beautiful job. Both of you did a beautiful job in terms of laying out how to make the diagnosis, the underlying pathology, and the plight of the patients, as well as a part that, is really critical, which is the nutritional counseling for these patients. I often think about when these patients develop diabetes after multiple episodes of pancreatitis, if someone hasn't made the diagnosis and sends them to a diabetes counselor and they get a diabetic diet, that's probably just the opposite of what they need. So understanding what came first, the pancreatitis and FCS, followed by diabetes versus the other way around, since we often see, new onset diabetics with severe hypertriglyceridemia also, but that responds to therapy. So there's a lot of nuances in the paper. Um, Nivedita, how did you get involved in this? And what are your thoughts on the value of the timing of this paper as well as the value for the practicing physician?
So I am very passionate about pediatric lipid disorders, especially the rare triglyceride disorders. I started my lipid clinic a few years ago, and I'm primarily seeing only triglyceride kids in it. The LDL kids are cardiology colleagues' interests, and I see triglycerides. And it is incredible how unrare high triglycerides are in kids, because when we started it, we didn't know the volume, but I have quite a few hundred kids in my clinic that have high triglycerides. Um, Rare disorders, not as much. A lot of them have a known secondary factor, but it's so difficult to treat because of, there's no specific targeted therapies for FCS, lipodystrophy, other high triglyceride disorder that, I feel constant uh, help in spreading the word for diagnosis, early prevention, making sure they get diagnosed before a lot of pancreatitis happens, because otherwise the secondary diabetes is the potential aspect too. So I've always been out and about trying to diagnose, find, help these patients.
Well, I appreciate this. I'm very passionate about this disorder also, just from having several patients over the years. I started my lipid clinic in 1987 and thought I was very smart at the time. And when I look back on it, I probably missed a few FCS patients that I couldn't figure out the diagnosis. Some of them had triglycerides 4,000, and occasionally they didn't have pancreatitis. I just remember they didn't respond to any therapy, and they either gave up on me or got accused of, not following the diet or drinking, etc. But it was very frustrating. And I remember every single patient I saw like that over the last 40 years. And as I got smarter over time, which is, I think, just because I finally realized I wasn't so smart. So I started looking more carefully at genetic disorders. But as I learned more about FCS, then we actually identified several patients and got to at least give them the appropriate instructions. Uh, One patient I had, I remember we gave fish oil over and over until he finally came in my office and screamed at me. And many patients with FCS tolerate fish oil, but it doesn't lower their triglycerides. But this patient got pancreatitis every time I prescribed it. And he told me that. I asked my fellow board members at the NLA 25 years ago. They said that doesn't happen, but it certainly does. We were giving him fat, in the form of omega-3. So a lot to learn about these patients, and even experts in the field are learning more and more. And I think with new therapy that was just approved by the FDA, there's going to be a lot more interest. So, Fiza, why don't you kind of walk us through the key sections of the document and what our audience members should think about in terms of what to look for when they review the paper?
No, for sure. I think Dr. Brown, you made a really valid point about just knowing, just to recognize when you should be alarmed or be thinking about rare causes of chylomicronemia, because I mean, people can have really high triglycerides, even in multifactorial chylomicronemia. And we have to, as much as we are passionate about FCS and when to recognize it, it is still a rare disorder compared to MCS, which is we're much more likely to see, and for it to much more likely to be that. So I think one of the key points that I definitely think about is just the prevalence is still sort of up in the air. I've seen all sort of numbers from 1 in 100,000 to 1 in 1 million. And right now, I think we're thinking it's like average 1 in 300,000. But you have to think also about like the geographic location that you're in and the risk factors for the condition itself. So if you are in French Canada, the prevalence is much higher and it's not as rare compared to other parts in the world. Or if there's consanguinity between the parents, that's also a risk factor for a rare disease such as FCS, and that's when you see there's multiple. I know a family myself that has 3 FCS patients within their family. So for them, it's not a rare disease. So I think it's important to think about that. But just thinking about the distinctions of like when your alarm bells should go off in FCS versus MCS is just a younger presentation. I think just the younger age presentation is generally pediatric or adolescent population in which that you're more likely to see it. You have this hypertriglyceridemia, but you're not really finding the obvious like secondary causes of hypertriglyceridemia, things like alcohol or obesity or insulin resistance, diabetes, things that people can actually address. But the actual features, I think, are the actual just the serum triglyceride levels themselves. And people are able to, a lot of FCS patients just generally live at 20 to 40 millimoles, or I have to change the term for the Americans here to 17, like anything over generally 1,000 milligram per deciliter is severe hypertriglyceridemia. But in FCS patients, you're thinking even higher, generally like 1,700 or over 2,000, 3,000 or people are walking around with that. But when you compare that to like MCS patients, for example, you might still get like something around like 10 to 20 millimole, but you don't generally see over 2,000, 3,000 levels, and the threshold at which you might get acute pancreatitis itself. I think the other thing that people think about when it comes to hypertriglyceridemia is also just like what is the primary lipoprotein disturbance that is actually present. So in FCS, it's primarily chylomicronemia. If you look at MCS, they have other elevations as well. They might have more increases in VLDL and remnants, which you don't really see in FCS. That can be key factors, or just testing for ApoB. In most patients who have FCS, they tend to actually have lower levels of ApoB compared to patients with multifactorial chylomicronemia syndromes.
Yes, that's such a good point, and it's fascinating why that is. So this is one of those things that, again, experts have bantered about. Why is the ApoB level so low in FCS patients, which you certainly wouldn't expect in the multifactorial? So you really touched on a few topics, and this is something that I'm going to squeeze Dr. Patni about, but one of them is the earlier age of onset. So I know Nivedita, you're very interested in that age group, so we'll talk about that. The other is low ApoB, absence of secondary factors, smaller body mass index in general, and then the final piece is the refractoriness to therapy, right? These patients just don't seem to respond to therapy. So anyone who's triglycerides are over 1,000 is going to have a poor response to therapy just because they've saturated their lipases, and all of our drugs that try to enhance lipase activity don't work until you make them NPO, and then their triglycerides get down below 1,000, and then the drugs work. But that's not true with FCS. They rarely would get below 1,000, even NPO, and don't seem to get a response to your therapy. So non-responsiveness to therapy should be a red flag, and all the other things you beautifully pointed out, Fiza. So Nivedita, you love the pediatric hypertriglyceridemics. You told me a little about this earlier. You're passionate about it. Tell us a little bit about your experience with these patients, and what should pediatricians be thinking about in the hypertriglyceridemic patient to kind of identify the FCS patient?
So I think the first thing is to actually identify the neonates and the young ones. I actually recently got 2 kids less than 1 year within the last few months span. Because most of the neonates and early infancy presentation is just discomfort, vomiting. So they would go to ER with not tolerating PO, they're vomiting, and it's assumed to be a standard gastroenteritis virus. There are so many things happening, and most of these babies don't even get blood drawn because they come, they're hydrated, then they're sent. unless there's a reason that somebody wants to look at chemistries, a lot of urgent cares don't even think about picking these kids. So the two kids I've had in these last few months actually have their blood drawn and very obviously lipemic. And then they called me, oh my God, Dr. Patni, I think we have somebody who should be in the clinic. But at early onset, within the first 2 months of life, their triglycerides could be as high as 5,000, 6,000, especially in their acute illness phase when they are dehydrated, it is that high. So I feel just the awareness that it's not as rare. It's not really 1 in a million, maybe a little more common. And if your acute abdomen is suspicion and there is no real symptoms of viral gastroenteritis, let's at least just draw blood. Uh, to not miss it. Again, I know it's a rare disease and it's too much overkill to tell every urgent care and urgent care to do it. But we've had these discussions with some of the other pediatric lipidologists if it is going to be value to just make it part of newborn screening as well, because a lot of newborn screening disorders are much rarer than this. And they follow a specific, we're just getting the pinprick and LCMS, can triglycerides be made it? And it would not pick up in the first one within 48 hours. I don't think anybody would have it. But breast milk is such a high fat intake that by the second one, which is about 2 weeks age, I really think that high triglycerides can be picked up. The tricky thing with that is we really don't have norms for 2 weeks of life. So I'm not sure if the standard can be if anybody is over 1,000 only, then mark it as abnormal or not, because neonates could honestly be running in 200-300s all the time because they're just having breast milk, which is a very high fatty. But diagnosis is missed a lot because it's so non-specific discomfort in a baby that goes and they vomit and they get hydrated and they're sent home. So I've had kids who are presenting that early, and I've had kids who presented at 13, 14 with symptoms that they just always feel bad after a fatty food and they sleep on it and in the morning back to life.
Yes, I have seen that also, and it's very interesting that with the same genotype, sometimes the kids behave differently. So
Yeah.
I have a patient who had 30 episodes of pancreatitis over time from 3 years old till she was about 28, and then her sister has exactly the same genotype and only had 1 episode of pancreatitis when she was pregnant. So she must have some other SNPs that interact with her triglyceride metabolism somehow. It's fascinating to me.
It's fascinating how so many polymorphic effects happen with so many other things. So there is a big spectrum, even if we are finding 2 hits, and even with the different 5 genes, ApoA5s and LMFs probably are not behaving as GPH, BP1s, and LPLs, deletions versus, so I think the spectrum is so big that it's not as straightforward, but yeah, diagnosis definitely gets missed. And the therapy part too. From my perspective, it's all diet, at least right now. I'm blessed to have a good lipid clinic with great nutritionists in my clinic. They see all the kids with me. And so we get together, we have decided if this is what we're looking at, this is the dietary guidance recommendations. And I think it's a good era, honestly, because everybody has a phone in their hand. Everyone can download apps. They can scan the barcode. So we give them very concrete numbers. I know adults like to go in percentages, less than 10% or 15%. With kids, I am very straightforward with the grams. Most of my kids stay around 10 grams of fat a day. And that has actually, at least in my experience with the very few I have, has kept them very nice in the normal less than 1,000 range. But with the apps, I think it helps a lot.
Yeah, that's great. Yeah, so not having formation of chylomicrons from reducing the fat in the diet has been the treatment, and still is in the pediatric population, because these patients can't clear the chylomicrons, which gets us back to the interesting fact that the ApoB is so low. So you would think in the absence of lipoprotein lipase activity that not only would chylomicrons not be broken down into remnants, but VLDL would not be broken down into intermediate density lipoprotein. And so there should be a lot of VLDL floating around also. So Dr. Hagley, who's one of your co-authors, pointed out to me that somewhere around 75% of the substrate that the liver uses to make VLDL comes from dietary lipids, which are being picked up by the liver in the form of chylomicron remnants. So since these patients can't convert chylomicrons into remnants, the liver doesn't have the substrate to make VLDL, which is why the ApoB is so low. I've also heard other theories that hepatic lipase has a better affinity for VLDL than it does for chylomicron, so it might better metabolize the VLDL. There's a lot of discussion about this, but I like the idea that there is less substrate for the liver to make VLDL. So their ApoB levels are very low since ApoB is ApoB 100. And we think that in general, their risk for atherosclerosis is quite low, though you can't say that with 100% certainty. Again, very interesting from a lipid geek standpoint, from the patient standpoint. We like to separate this out from other forms of hypertriglyceridemia, as you guys had already kind of alluded to, right? Such as metabolic syndrome or familial hypertriglyceridemia, which is a different disorder. That's a dominant disorder. In this scenario, the parents really don't show much hypertriglyceridemia. They could be mild or normal. And that's one of the clues, since this is the recessive form of a very severe hypertriglyceridemia. Fiza, you know that we did the North American scoring system, and as you were preparing this paper, did you have any thoughts about that? And a little more about diagnosis, and then we'll get into some of the therapeutics as well as a little more on the diet.
I think the North American FCS score, prior to that, there was the Mullen score already that existed. But what I actually really like about the North American FCS score is it basically takes into account all of the things that we were talked about earlier that makes you think about FCS. It has parameters for age, BMI. We know that BMI tends to be lower in patients with FCS because their main issue is it's not obesity that's driving their hypertriglyceridemia. It's a genetic predisposition to it, and the history of pancreatitis, because most patients with FCS will have at least at minimum 1 episodes, and most patients that I know have had from their lifetime, from being born up until their by the time they're middle age, at least have had over 20-30 episodes at times of recurrent pancreatitis. I think it's a pretty good and quick, fast score that you can use. And makes you think about want to do essentially perhaps genetic testing if you think it's high enough that it meets criteria. And actually, the North American FCS score also has somewhere called the gray area, where it tells you that it may be FCS. We have in the actual paper, we just have like a screenshot, but it's available as an actual algorithm that you can just select now, that we have a link to. And I think it's a pretty good tool to use if you're trying to recognize patients in your lipid clinic or in primary care, even to see whether you think somebody might have FCS.
Yes, and I was happy to see that, the one company that now has a therapeutic agent, Ionis has Tryngolza, as it's olezarsen, a new therapeutic agent, which is a antisense oligonucleotide against ApoC3. They have actually put together an app, basically, where you can plug in North American scoring system components and get a score. So I was happy to see that. I thought that those of us who participated, and I know Nivedita, you participated in that North American scoring system also, we were going to get an app at some point, but they did it, so that's nice. And hopefully there'll be something you can put on your phone at some point. So I wanted to Nivedita, tell us a little bit about the diagnosis, and you kind of alluded to the genes that can lead to FCS, and let's delve into that a little bit more, and maybe a little bit about what the differential diagnosis would be, other disorders that could masquerade as FCS.
So, I mean, I'm glad you started off as us as the lipid geeks, because I think we are all into the pathophysiology, the pathway, how the chylomicrons form, the ratio of triglyceride total cholesterol. So honestly, I think the diagnosis can start with just the lipid, right? If you're seeing a ratio of 10:1, you think of chylomicronemia, because the chylomicron is the biggest fat we know, with 10 of triglyceride and 1 of cholesterol. So the geek crown starts right there. Let's start thinking it is more of chylomicron versus VLDL or the other things. Now we have access to ApoBs, which is also helping us see more of is it B100 versus the B48, which I'm sure all of us know. So it's not 100% that you'll have it low. It's about 60 to 70% if the ApoB is less than its FCS and MCS. And that's why the scoring, I think, comes. And it's important because there are multiple factors that have to fit in to give the total score. There is not one thing. If you get diagnosed at 2, you have this. If you are skinny, then you have this. I'm glad that we have all of the factors to take into account and then come up with because of the spectrum and the variability. Secondary factors are still pretty common in kids too. I have seen kids with severe hypothyroidism who are presenting with triglycerides of 500-600. Chronic kidney diseases, nephrotic syndrome, say obesity, diabetes. So primary, again, the diabetes question, we started with that too. It's always important to ask what came first. If I'm getting a kid at 12 with nuanced diabetes, but he's saying since he was a little baby but has been having recurrent belly aches after every fatty food, I would probably start thinking, okay, let's see what was happening first. Did diabetes come first or the pancreatitis recurrent happening and that caused it? So diabetes question is always important, but doesn't rule out the secondary thing. It's probably incorporated because I've had plenty of lipodystrophies and FCSs who presented with diabetes, but had things going on before. But yeah, ruling out secondary factors. Again, my practice, and I think more because I'm from Texas, we have a big obese population. So just the secondary and the familial hypertriglyceridemia is pretty common too, and it comes into play. So ruling out the secondary and then thinking with the scoring and then trying to get genetics is the right way to proceed to diagnose FCS.
Yeah, up to 30 or 40% of these patients that clinically have FCS may not have the classic genotype, which would be those 5 genes we had mentioned: ApoA5, lipoprotein lipase, LMF1, GPAH, BP1, and ApoC2, or some combination of those, with the vast majority being lipoprotein lipase homozygotes, or compound heterozygotes or double heterozygotes. But
there's also autoimmune etiology.
Yeah. Yes,
still not commercially
I'm
tested.
glad you brought that up. That was what I was going to ask about next, because we have seen those. I have one, and you probably have had
a couple I haven't tested, but they presented with type 1 diabetes and they are toddlers. So I know they don't have any other secondary, but well-controlled type 1s with high triglycerides, I'm presuming them to be autoimmune high triglyceride as well.
Yeah, ours was a lupus patient. So the autoimmune diseases, lupus, Sjogren's, etc., they have actually shown, interestingly, different autoantibodies that cross-react with those 5 proteins that we discussed. So my patient, after 10 admissions, she was genotype negative, and that's what I was going to say. About 30% of 40% of these patients have a negative genotype, but in every other way, they fit the scoring system to have FCS. And we had this discussion when we were trying to do the North American scoring system. What do you call those people? And they should be able to get therapy, right? If there is a therapy, it shouldn't be based on genetic testing, because if 30 or 40% of these patients that are having recurrent pancreatitis and no response to therapy act just like FCS, and their only treatment is the currently available treatment for FCS, we need to have a name for that, which we called functional FCS. And I was very happy to see that in the manuscript. I thank Rob Hugley for that, because I know there was a lot of discussion. So even though it isn't classic genetic FCS, so we had a 13-year-old South Asian patient who was diagnosed with functional FCS because she came in every month with pancreatitis despite a good diet. And on her 10th admission, had proteinuria and had a renal biopsy, which showed lupus nephritis. So we actually sent her blood out to Steve Young, who had published the development of autoantibodies against GPI-HBP1 in patients with lupus, and she, quote, lit up like a Christmas tree. So after immunosuppressive therapy, her FCS syndrome was cured. And I think with Sjogren's, you get autoantibodies against one of the other proteins, maybe lipoprotein lipase, if I recall right. But I think it is worth thinking about when you have a patient who has any sign of autoimmune disorder and clinically FCS, that they may actually have autoantibodies against one of those proteins and should respond to immunosuppressive therapy. And that might happen more than we realize. I don't know. I think that's something we should keep in mind.
I think
Fiza,
Dr. Brown, you brought up a really interesting point because yeah, Dr. Gade, Dr. Hegley, Dr. Ahmed, and myself had a few discussions about what we are considering functional FCS. And one of the points that I sort of think about is, you know, like with autoimmune, like SLE and other things, or even specifically auto antibodies that are developing to say like LPL themselves, those are treatable causes. And although they may present like FCS, we didn't necessarily want to call that functional FCS because it's reversible and it's not FCS. Because one of the features that we're talking about FCS is that it's not responding to any known therapy. Because there's obviously another subset of population, smaller, but that exists, where we haven't found any gene, we haven't found any other cause for this severe hypertriglyceridemia, yet it's not responding to any therapy at all. And there's some still debate about, we don't know, maybe we're missing some other casual, like other genes that we don't know about. Although I think Dr. Hegley might disagree from his whole genome sequencing that there are other FCS causal genes, but there might be other things, you know, like there's like CREB3 and then we might be missing something, and that hence we don't, because right now we can humbly say we don't have an answer for those patients, and they will still need therapy and they will still need access. So for those, that is functional FCS if you have no other explanation for the severe hypertriglyceridemia for which there's no therapeutic that's working.
yes. So I think that idea of a 10-to-1 triglyceride to cholesterol ratio, which tells you that almost all of the lipids are chylomicrons, because any other lipid particles would dilute that ratio down, right? Because they all have less triglyceride. So that would be clue number one. Number two is doing genetic testing. And if you see that the genetic testing appears to be negative and you exclude secondary causes, and I would consider autoimmune disease as a secondary potential cause, then you still have a fair number of these patients that don't have any of those characteristics, but act exactly like FCS. So that's kind of what we think of as functional FCS. And I know Rob Hegley and Dan Gade have their series of SNPs that seem to cluster together and maybe the culprit, and they're working on that. But regardless, it's great to know that we have a therapeutic agent for these patients now. So let's take a second to talk a little bit about the therapeutic agent, and then I'm going to ask you guys to conclude with what you think the most important. I'll let each of you say what you think the most important implication of having this position paper is, because it was a lot of work and I read it very carefully. I was really impressed with the breadth and scope of it, and also the readability, which I thank you for. You know, a lot of times it's difficult for someone who isn't really fascinated by this particular disorder to read through a position paper. It was very well done. So, Fiza, do you want to talk a little bit about the current first therapeutic agent available for patients with FCS, the olezarsen?
Yeah, for sure. I think it's definitely a really exciting topic. Yeah, olezarsen is FDA approved. It's available, at least in the States right now. From patients are able to speak to, I think, the representative as well at Ionis, and they can help connect and figure out accessibility. So olezarsen essentially it's a more advanced form of the volanesorsen drug that was earlier, which is still available in Europe actually for treatment, but not so much in the States due to thrombocytopenia. But looks like because olezarsen is approved and it's better and it doesn't have the same kind of thrombocytopenia concerns, is definitely a better improved drug. So it's yeah, a lot of patients who were in clinical trials had significant reduction in triglyceride levels. But I think one of the more important aspects is just reducing acute pancreatitis events, which in the placebo arm of the olezarsen trial had, I think there was only one pancreatitis event compared to 11 in the placebo arm. So I think everyone is really excited about it. This is the first drug therapy that's actually out there that can be used in FCS patients. Plozasiran is also, I think they've already submitted their FDA application, which is an siRNA, again, targeting ApoC3. And the idea is that if you inhibit ApoC3, which if you think about it, theoretically shouldn't work because it's an inhibitor of LPL, and you're targeting that in patients who don't have lipoprotein lipase. This was actually one of the first questions how I had gotten involved in FCS research. I had reached out to Dr. Hagley about after volanesorsen as to how ApoC3 could possibly work in FCS patients with no LPL activity. And I think we don't have clear idea, but we have theories. And our theory is that it's doing it through alternative pathways, or through increasing activity of other lipases, such as hepatic lipase, that might be reducing the triglycerides. So I think for patients, having spoken to patients, the patients for the first time, I think, are seeing levels that they have never seen in their entire lifetimes. There's a lot of enthusiasm, but also I think there's uncertainty about what that really means for a possible liberal, being liberal in the very restricted fat diet. From so far that we know, it's going to be an adjunct, not necessarily change significantly the dietary fat restriction.
That's a very good point, and I know that that patients are supposed to continue on their very low fat diet. So Nivedita, I actually don't know the answer to this question, but how young of a patient can you give olezarsen, and what are your options in the pediatric population?
So we cannot use it in pediatrics yet because the data is all 18 plus. Good news is I heard they are trying to start trials in the kids. I think they're going to do it in two phases. So the first one is going to be 12 to 17, and then they want a younger population too. In kids, honestly, at this point, keeping them on low-fat diet, and majority of my kids also get orlistat, which has helped them keep in the normal range pretty impressively. So the pancreatitis risk and triglyceride in the normal range has been, at least all my patient population, I feel, are successful. Their main frustration is how low fat they can eat. And when at some point in their lives, they want to be able to eat like their friends and family members and other people. So I know at this point, these newer drugs are working with the goal of less pancreatitis and safety, but they have not allowed more liberal fat intake. But I think at least with my patient population, with the kids, their hope is, when can we start eating more?
Yeah, and we have to keep in perspective, it's a relatively small number of patients. I mean, the balance trial, which
Yeah.
Fiza quoted, only had like 43 patients in it. So as we get more experience with patients being treated around the world and what they're able to do, we would see. But I would assume for them, fat is like antabuse, you would be very nervous about liberalizing fat because the downside risk of pancreatitis just might not be worth it.
But it's that tricky range of transitioning from adolescence to adults. So I have been honestly very lucky to have great families. I feel all of my families do great with counting fat, giving them. So the kids do great. But when they are at that teenage age and trying to transition out, that's when families are starting to worry because kids get rebellious. They want to have them a normalish life. So I feel that from that 16 to 18, 19 is the phase when they really want things to happen.
Yes. So since you're a metabolism geek like I am, Nivedita, so Fiza brought up a good point. ApoC3 is a fascinating protein. It does 1,000 things.
Yeah.
And the initial idea that since it inhibits lipoprotein lipase, if you remove it, it might reduce, it might increase lipase activity in these patients with FCS. I mean, I agree with your comments, Fiza. It doesn't make sense. If you remove inhibition on a protein that doesn't work, it still shouldn't work. But it does. And I think the current feeling based on some animal data is it when you remove ApoC3, you upregulate some receptors on the liver that can pick up chylomicrons in the absence of lipoprotein lipase, the so-called lipase independent pathway. But Fiza brought up a couple of interesting points about ApoC3 inhibiting hepatic lipase also. And when you remove that inhibition, does that maybe help in metabolizing chylomicrons? And so what are your thoughts on maybe the mechanism of action? And then we'll talk about final comments on the paper.
Yeah, no, I wish I knew more. I really think it is these alternative pathways. The same with ANGPTL3 and now the whole idea of maybe ANGPTL4, right? With the kids who absolutely have no LPL, it's difficult to comprehend these medications working because, and that's why it was my whole thing when we started Orlistat. The only thing you can do is decrease the absorption because there is nothing downstream for you to act on. But clearly, from the data we have, they are working. So they have to be alternative pathways. Other things are getting activated on liver to uptake them. Um, and I'm going to bring back to, how we've always felt Tricor doesn't help and VLDL is not getting activated. Again, with my small sample size, I do have a couple kids who, with Orlistat and with everything, in the end, when I added Tricor after the fact, it does seem to help. It didn't help early on. When it was given as a solitude, when it was given as a single agent, it didn't. But I feel when I decreased the fat absorption even more, and they were such carb-heavy diets because they're not having any fat, I think the ApoBs went up, VLDLs went up, and then I added Tricor. And somehow the combined effect is keeping them in less than 300, 400 triglyceride range. So this physiology also changes depending on the diet at exactly what point we are adding. So I have these couple kids who Tricor after Orlistat is helping them keep even a better control.
These are genetically proven FCS patients. So
Yeah.
that's fascinating. For those who don't remember Tricor, it's one of the brands of fenofibrate. But yeah, that's interesting.
So this is a kid who's 8 or 9 year old who saw several different doctors before they moved to Dallas, actually, apparently, because they knew that I do this. And they had tried everything before from omega-3s, fenofibrates, nothing had worked. Then he's doing great with diet and Orlistat, but then the triglyceride tried creeping up. And when I look at the diary, they're primarily eating carbs. He's a growing boy. So he's eating so much carbs that I think the VLDL pathway started getting activated. So I did discuss the mechanism with them. They're a very smart family. I'm like, I think we have to suppress that now. And we did, and it's staying 300s.
That's really
Close to
fascinating.
3,000, right? That like he would have 20 grams of fat, he's going to be 3,000. He stays at 10 grams with Orlistat and Tricor and doing great.
So if any of you in the audience are metabolism geeks, I would challenge you to read about ApoC3. You'll be kind of fascinated by all of the physiology of ApoC3. Number one, as we mentioned, it inhibits lipoprotein lipase and inhibits hepatic lipase. It also stimulates insulin resistance. So it has effect on the peripheral tissue to make it more resistant to insulin, and it can be made in the islet cells in the pancreas and actually lead to apoptosis of beta cells. So should be potentially pro-diabetic. I always wondered why C3 levels seem so high in patients with metabolic syndrome. It seems like overeating and obesity increases ApoC3 formation. So it has so many different functions. And interestingly, if you look at populations where it's knocked out, there's a pretty low risk of atherosclerosis. So a lot of potential for ApoC3 as a target in the future, not only for severe hypertriglyceridemia, but maybe other things like reducing atherosclerotic risk and maybe reducing the risk of developing diabetes. But it is really fascinating, all the things ApoC3 does. And the more I read about it, the more I wonder why we have it. And why would it go up in the patients you at least wanted it to go up in? One other point is one will notice when you look at the olezarsen data that the LDL tends to go up a little bit when you put the patients on olezarsen. And that's probably pretty obvious from what we discussed today. Why that happens is now you're metabolizing the chylomicrons, they're getting into the liver. And so your liver can produce more ApoB100 containing lipoproteins like VLDL, which will become LDL. So you would expect the LDL to go up a little bit, but interestingly, didn't go up very much. And the vast majority of the patients never got over 100 LDL. And of course, these patients have a relatively low atherosclerotic risk anyway. So I'm not sure that's an issue, but it's something we talk about. So we covered lots of topics today, but which the paper did too. I think it's required reading for all lipidologists, in my humble opinion, to know about this disorder. It tends to get mentioned as a rare genetic disorder and lectures on genetic lipid disorders, but this is really a nice, wonderful, comprehensive, and readable document. So let me ask you two to just finish with, we'll start with Fiza and with Nivedita on what do you think the most important points do you want to make about this paper, and why should the folks in our audience take a look at it?
Yeah, for sure, Dr. Brown. I think actually, first of all, I did want to respond just briefly to a point that you made earlier about ApoC3 and its role in maybe helping insulin resistance. Because there is some data, early data on plozasiran, that in patients who had prediabetes or diabetes already, they actually got mild hyperglycemia, and their A1Cs had worsened a little bit on ApoC3 inhibitors. So I think there needs to be a little bit of caution when we're prescribing these agents. And then the second aspect of what we were talking earlier is, like, if we're using these kind of drugs in FCS patients, we don't want to necessarily without further investigation or further clinical studies to show that these still work long term with less adverse events in the MCES population as well. Because in multifactorial, for all we know, FCS patients are already starting with pretty depressed like LDL levels. But if it's stimulating so much activity, we don't know what's really it might be doing to the atherogenic potential for say MCS population. So just something to think about. I think we
No,
just
those are both very good points. Yes, I remember that paper about the glucose going up. Wasn't sure exactly what the physiology of that is. Kind of the opposite of what you'd expect when you remove ApoC3. So I'm glad you made that point.
yeah. So yeah, I think we are excited, but we should approach everything with caution until we, have a little bit more long-term efficacy and safety data on
The
the
absence of data gives one the illusion of adequacy. That's what we say.
But yeah, I think with FCS, my one of the things that we didn't sort of touch is, of course, this is a lipid disorder, and those of us who are passionate about lipidology care, we see these patients, we see how how this affects people's lives. But this is the second aspect. This is for patients who live with it, it's not just a lipid disorder. It's impacting other spheres of their lives, their ability to socialize, their ability to go to social events, be part of family events, or just go out to a restaurant. Things that we, as an average population, take for granted are not so easy for these patients. So I think if we, for as clinicians, if you see somebody that you think has severe hypertriglyceridemia, it just want people to think about FCS. And if you see kids with recurrent abdominal pain with hypertriglyceridemia, maybe also think about just even a simple test, such as a blood test that might show lipemic plasma that might lead you to do other investigations. I think that I'll just leave it at that and read the paper, and maybe it might help shine a light on some more things that you want to learn about.
Yeah, so you can extend that to the emergency room. Every patient that comes in with pancreatitis should get a lipid profile. It's kind of shocking how few of them do, either by the gastroenterologist or the emergency physician. So,
Absolutely, absolutely. I just saw 3 acute pancreatitis in the past week, and I was the only one who had ordered a lipid profile because it just wasn't, it's not a standard thing that people do. And it's actually a second most common cause of pancreatitis after alcohol. So
yeah, so there is a push by the pancreatology group society to put a protocol in place for everyone coming in with pancreatitis that includes lipids. So Nivedita, I don't want to steal your thunder. Great work on this paper, both of you. But Nivedita, do you want to give your final thoughts on the document and why our audience should read it?
No, so just echoing Fiza's thought, I think it's just more awareness, it being such a rare disease and people don't keep it in mind. Early diagnosis helps a lot because lower fat diet, along with these upcoming new therapies and orlistat in kids, it helps keep them in the safe zone. So picking it up early is very important because we have new exciting things coming up, and helping manage is going to be easier then. And plus, there are experts they can call, and always call us if you need us. So we
Yes, these patients should all be referred to a lipidologist. Does everyone agree on that?
happy, and we'll be happy to see them talk to their doctors, anything that takes.
Well, I'd like to thank you both for number one, a wonderful manuscript, and one that I think will be a resource document for years to come, and also for your excellent thoughts today on the podcast. And thanks to all of you in the audience for joining us today on this Lipid Insights. We're talking about the expert opinion statement that is published in the Lipid Journal on familial chylomicronemia syndrome. Thanks again for joining us today.
thank you so much.
Thank you.